So once again, we continue with looking at anatomy with movement as our central point of meaning in our network of meaning or in our semantic network, so that we understand it with relation to movements, especially with respect to assessment and treatment, where instead of absolutely picking apart all the small things, we're trying to orient you to the areas to consider if there's a problem with the motion. So here we're looking at wrist extension or radiocarpal extension. Now, the main objective is a specific discussion of what wrist extension is, so the planes and the axes, general discussion of the muscles that perform this action, the nerves that innervate those muscles, the general vascular supply, and the general discussion of the areas to assess and treat should issues with wrist extension be suspected by the practitioner or reported by the patient. So our general look at planes and axes. So we just do the quick review. The sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body back to front. The axes are perpendicular to the plane. So the sagittal plane, you have a horizontal or transverse axis. The horizontal plane, or the transverse plane, you have a vertical axis. The frontal plane or the coronal plane, you have an AP or PA axis, or anterior to posterior, posterior to anterior axis. In this case, wrist flexion, that shouldn't say flexion, it should be wrist extension. Wrist extension with the hands at the side, the thumbs facing out. Wrist extension is movement of the palm away from the front of the body, or the dorsum of the hand, the back of the hand, towards the back of the body. So it's movement of the fingers, you could say, or the palm towards the back of the body, or towards the back of the arm. So out of plane. So in plane, or out of plane, I could do this. This is wrist extension. I can do it here. This is wrist extension. I can do it in awkward settings. This is wrist extension. But with respect to the anatomical position, with the hands at the side, the palms up, or the thumbs out, it is movement of the back of the hand towards the back of the body. And that occurs in the sagittal plane along a transverse axis, or a relative transverse axis, that is determined by muscles, as well as the relationship between the proximal carpals and the distal radius, right? So it's radiocarpal extension. So the muscles that are going to perform this, again, we're not necessarily going to break them all down and be extremely specific, but you're looking at the extensor digitorum, the extensor carpi radialis, and ulnaris. One of them has a longus and brevis. You're looking at the extensor pollicis longus, not brevis. So generally speaking, there's a fair amount of muscles in the posterior compartment that are going to be considered extensors. And if you see carpi on there, then it's going to extend the wrist. In this case, pollicis longus, and then digitorum, as well as the carpi radialis, extensor carpi radialis and ulnaris are going to generate extension of the wrist. So again, instead of breaking these all down piece by piece, noting that the general region that you're looking at is the posterior surface of the forearm. And in general, even in very muscular people, the muscles are not going to be as accessible here. This is going to be a less meaty area and a more bony area. So it's harder to interact with these soft tissues. As far as actually palpating and manipulating the tissues, it generally speaking ends up being easier to mobilize the wrist itself when considering treating the specific joint or the specific motion. Now, the neurovascular bundle, essentially what you're looking at is the radial nerve as the radial nerve or as a branch in the posterior interosseous nerve. And then you're considering essentially the radial artery, the ulnar artery, and the posterior interosseous artery here. So depending on the muscle that you're talking about, it's either on the ulnar side, the radial side more so, or it's more in the middle. So the ulnar side is going to get from the ulnar artery, the radial side is going to get from radial artery to some degree, and then the posterior interosseous artery will get more of the stuff in the middle, or more of the muscles in the middle. So the neurovascular bundle is again going to direct you to the posterior surface of the arm when you get there. It will also, rather the posterior surface of the forearm, it'll also allow you to consider looking at the posterior surface of the arm, as the radial nerve is going to descend with the tricep primarily. So you may actually have to go up the back of the arm when considering when wrist extension with respect to the nerve, not the artery. So the nerve is going to take you to the posterior surface of the arm. It's not going to take you there for the artery. The artery is going to take you essentially from the anterior surface of the arm to the posterior surface of the forearm. The areas of consideration for assessment and treatment, the cervical column, as always with the arm, right? So the neurovascular bundle, be it the subclavian artery, vein, or the brachial plexus. The brachial plexus, the subclavian artery, primary relationship between the anterior and posterior scalenes. The nerves or the brachial plexus, the actual bones of the neck. Then you're considering the clavicle or the axilla as far as the descent of the artery and the vein, and the descent of the artery and the nerve, or the ascent of the vein. Again, that's neurovascular bundle. In this case, you're considering the anterior and posterior surfaces or soft tissues of the arm with respect to wrist extension and the descent of the arteries and the nerves. The nerve being a little bit more so concerned with the posterior surface of the arm. Now, you're also then going to be considering the posterior soft tissues of the forearm. So it's not just the muscles, it's the neurovascular bundle. But as we've said, interfacing with the muscles here is more difficult because even in well-muscled people, these muscles are not as pronounced. They're not as meaty. You're going to get more so into bones here. It's also fairly uncomfortable when you're working with the posterior surface of the forearm, such that you're more likely to generate a pain response in most people most of the time. There will be times when you can work here without that pain response and respecting the barrier appropriately, or the barrier concept, but you're going to have a harder time. So as with most things, when you get out of the central region, you get, or the axial region, you get more into the appendicular region, and you're not necessarily in the head or the neck. Your contraindications and your red flags generally get smaller, especially when the area of concern is more localized. So in this case, a known fracture or tear in the region, you don't treat the fracture or tear. You can treat the patient, but you don't treat the fracture or tear, as you run the risk of causing more damage to the region where the fracture or the tear lives. A suspected fracture or tear, you refer out for confirmation or for a differential diagnosis, showing you that it is not a fracture or a tear in the area, because a known fracture or tear, you don't treat. A suspected fracture or tear, you refer out for confirmation or a differential diagnosis at a level that, as a hands-on practitioner who works from the outside of the body, that you're not able to generate.